Secretary Azar, thank you for being here. Thanks for all the work. You've done a lot of work to be able to help folks have opportunities to get greater health care and greater health care options. I appreciate very much. I want to bring up something that's new that you proposed that my state actually was first in line to be able to engage in. That's the Healthy Adult Opportunity Initiative to be able to allow greater flexibility on Medicaid so they can tailor it. Oklahoma is not the same as Alaska. It's not the same as Illinois. It's not the same as New York. And so allowing some greater flexibilities. Where does that stand at this point for the Healthy Adult Opportunity Initiative?
So we have put the guidance out to the states and are now really open to working with states. I think it's very important to remember, because a lot has been said about this opportunity for states to apply for this flexibility. This would preserve, the insurance would have to cover essential health benefits. No individual would be deemed ineligible. The eligibility requirements for the Medicaid expansion under the Affordable Care Act would remain. There would not be either partial expansion or partial de-expansion. So this really would be for states to come up with ways in which they can provide a more integrated approach for these able-bodied adults. This is the expansion population, not traditional Medicaid, that's subject to this. And again, only if the state wishes to be doing this.
Right. It's something my state is currently exploring to be able to go through that process. You've also put out some proposals on Part D generic tiering to allow basically a secondary preferred specialty tier for drugs to try to get better benefits out there. If there's any recommendation I can make on that, is that we continue to be able to lean in on that and to be able to target generics and biosimilars to be able to make sure it's not just a benefit across the board, but it's really a benefit to those folks that are the consumers, that are the purchasers. Where does that rule stand at this point, and what are your thoughts on that?
So we have proposed that as part of the Part D regulations to create this second, allow the drug plans to have this second tier for specialty drugs. Those are the more expensive drugs. I think the specialty tier right now may be around $660 a month that triggers that. Right now, the regulations actually somewhat disable the insurance companies from negotiating bigger discounts from pharma because it has just the one tier. This proposal would allow there to be a more favorable tier, so not more restrictive for patient access, but a more favorable one to entice drug companies to give even more discounts in order to secure access to that tier of lower cost sharing for the patient.
It's one of the things that several of us in this committee are working through right now to provide multiple tiers and some other options for that and block some of the companies that are preventing drugs from going on the generic tier and pushing it onto the higher price tier. That's something we're trying to be able to work out legislatively. Several of us have mentioned things about the rural hospital relief. My state has seen seven rural hospitals that have closed of late. This is a big issue. Senator Durbin and I are actually working on some legislation dealing with critical access hospitals and getting greater flexibility there. I know you're also in a regulation trying to deal with that as well to allow them to be outpatient emergency hospital access and that critical access. Where does that stand at this point?
So I'm actually very happy that is in the President's budget this year to have Congress authorize us to allow that kind of flexibility so that a critical access hospital could have emergency function, outpatient, but not be subject to all the requirements of inpatient. In addition, the budget proposes that we'd have enhanced payments for those critical access hospitals that would elect for emergency, so they could be reimbursed at the regular emergency rate as well as a supplemental amount of payment for them.
Right. Well, we look forward to getting a chance to be able to walk through that because that'll be very important for all of us in rural states. And Senator Durbin and I will continue on with our legislation trying to be able to solve this legislatively long term. The University of Vermont Medical Center made a decision to have a nurse during an elective abortion be forced against her conscience to be able to participate in the abortion. Even though there were other nurses that were available and willing to do it, she was compelled to be able to participate that against her conscience. Your team has reached out to the University of Vermont Medical Center, has made requests of them to be able to find out where they are, what their standards are. It's been months on that. Has there been a response back in that process?
So as you know, with any of these cases in our Office for Civil Rights, we try to actually work towards a resolution that brings into compliance. The University of Vermont Medical Center refused to work with us on that, and reluctantly we had to issue a notice of violation in order to try to get their attention. Where things stand now, because that is a law enforcement matter, I couldn't go into detail about the back and forth on that. But the critical issue is we try to work with providers so that they get commitment to bring themselves into compliance.
Right. Well, we'll continue to be able to watch for that and be able to see what we can do. One last quick question is dealing with nicotine levels in vaping. There's not a standard level of nicotine. Obviously, several of the vaping devices choose to have very, very high levels of nicotine that they know is the most addictive portion of this. This is an area that we've raised to FDA before and to you before to say, is there a way to get a standard for nicotine so that these devices don't intentionally load them up with high levels of nicotine to increase addiction? Where does that stand?
So there's not a regulation under the PMTA, that's the authorization process for e-cigarettes that we have for novel tobacco products, a regulation setting a nicotine level, but in the course now, the May 2020 deadline that the court has set for these e-cigarettes to come in and apply for approval or authorization, under the PMTA, looking at appropriate nicotine levels will be one of the factors that we can examine at FDA in determining if an e-cigarette's entry into the marketplace is, I forget the standard, supportive of the or furtherance of the public health. So that would be one of the criteria that we can look at, is the nicotine level.